Okay, so I'll be speaking on Toxoplasma retinitis. So it is the most common form of posterior uveitis in adults and children, and it is caused by a parasite, which is an intracellular obligate parasite, which is Toxoplasma gondii. It most commonly occurs in individuals who are immunocompromised, pregnant women, and also in elderly population. The transmission can be either a vertical or what we say is a congenital transmission, or it can be through ingestion of these cysts that are there from contaminated food or water. It can also occur as a reactivation. Well, in the life cycle, basically the cats are the definitive host, and the humans are intermediate host. It can be infected by all these forms and cysts. So basically, we have two forms. One is the congenital form, and the other is the acquired form. The congenital form is basically from the vertical transmission, and if the mother is having a Toxoplasma infection, as the trimester goes by, the chances of the child having the infection is also, it increases accordingly. And it is basically a retinochoroiditis that is there at the posterior pole, and it is in a wagon wheel sort of a position shape, and it is bilateral. And if you can see, the amount of pigmentation that is there is a little bit more than what you would probably see in a macular coloboma. There is another congenital form, which is basically the Sabin's tetrad, in which apart from the retinochoroiditis, you also see hydrocephalus, intracranial calcifications, and cognitive impairment. Now, these are seen in a very few set of populations. Some of the literature says it's 2%, or some say it is 10%. The other form, which is the more commoner form, is the acquired toxoplasmosis, when the patient might actually land up saying that there is a unilateral blurred vision, or the patient is having floaters. If you see the anterior chamber, you will be seeing some amount of anterior chamber reaction in the form of either granulomatous or even non-granulomatous. The IOP is said to be risen in maybe around about 15-20% of patients, and typically what we see in the fundus is this whitish focal area of retinitis that is there, and you also get some amount of vitritis that is there. It can also be present in the form of a healed lesion that is there, that is the pigmented lesion that you see in the center, and a surrounding area of retinitis that is there, and it is when there is a reactivation. And lastly, it can be a severe form in which you are seeing this headlight in fog. The headlight is basically the area of retinitis that you are seeing by the arrow, and you can also see the disc just little bit on your right side, and yours what is the haze is basically the vitritis, and if you can see through it, it seems as if you are looking at headlight of a car through the fog. Apart from that, these lesions can also be somewhere near and near about the disc, and sometimes they can even lead to adjacent disc swelling. So it can be in the form of neuroretinitis, and the typical sort of perivascular sheathing that is there, and the exudates that are there, which you can see in this photograph, which are actually called the chiraless arteriolitis. The complications can also be there, that it may lead to a cataract or a macular edema or retinal detachment rarely. Then the other form is basically the atypical form, which occurs in basically immunocompromised individuals, specifically ones who might be on steroids, maybe because of a wrong diagnosis, or maybe immunocompromised by the immune status, or maybe an elderly patient who can have these sort of atypical presentations. So if you can see that what we were talking about is basically a focal lesion, and that also posteriorly, and now you are seeing these large confluent areas of retinitis which are there associated, and there is no scar that is there that you might tell you that it's a reactivation or something, and these patients are typically a differential for ARN. Again, this was another patient in which we had this peripheral retinitis that was there, diffuse. Apart from that, there was arterial involvement. Some parts of it was healing as well, because the patient was already on steroids. However, the patient was not improving, and when you do the lab workup and you see that the IgG levels are high. Another form of atypical is basically the punctate outer retinal toxoplasmosis, in which you get these deeper lesions, and that is the reason why they look a little bit more yellowish, because as we said, as you go down the retina and more towards the choroid, the lesions start becoming from white to off-white to more yellowish. and these can be multifocal. Multifocal doesn't mean that there are multifocal and different too far apart. They are next to each other only, but small yellowish dots, and they can also be a subretinal exudation as well. So to go to diagnosis, basically it's a very classical sort of a lesion, so it's not much actually to ponder on apart from the times when it is atypical presenting as an atypical form. So typically these retinitis are not associated with hemorrhages and any hard exudates, and on OCT you can see these as a very full thickness hyperreflective disorganized neurosensory retina, and when they heal on treatment, then you can see that the retina actually becomes thinner and some part of it becomes necrotic, and there is clumping of the RPE. So what you need to do basically to confirm, well, a typical form with detection of Toxoplasma antibodies, IgG, IgM, you can do them. You can support it with even PCR in cases where you feel that you are not totally, sure that it is that. And also you can do the Goldman-Whitmer coefficient, in which it is basically compared by seeing the IgG levels in the serum to the IgG levels in ocular fluids. So if you suspect a case of ocular toxoplasmosis, if you have a typical presentation, you can simply just go do a serology, and if it is positive, you can move on with treating the patient. If it is not, then it might be an immunocompromised patient in which the levels were not significant, and now you can probably go ahead with doing a PCR and confirm it. If it confirms, then again it's a diagnosis. It confirms your diagnosis. If it is negative, you need to go back and reassess whether your suspicion, your differential was right or wrong. In case it is an atypical presentation from the beginning, then obviously if vision at risk, you can do the set of examinations, which is seeing the antibodies as well as seeing the PCR and the Goldman-Whitmer coefficient, and in cases where it is more than 2, then it is considered to be positive. According to the Sun classification, well, it has to have a focal necrotizing retinitis, and it can be either A or B, A being the evidence of infection on the basis of either PCR or antibodies, or B being that there are typical findings like there is a hyperpigmented scar, and from the side of it is basically the lesion that is coming out. They are oval and they are round, and they can also be recurrent. So treatment wise, if you see the literature, classically they used to give a triple therapy in which they had pyrimethamine and sulfadiazine. However, those drugs were associated with some amount of bone marrow suppression as well as hepatotoxicity, and that is why the preferred right now is sulfamethoxazole and trimethoprim, and these are in double strength, so they are either present as Bactrim or Septran DS, and on the third day you add oral steroids to control the inflammation. For the antechamber involvement, you can probably give topical steroids. So as you can see, there was an area of focal retinitis, there was arterial involvement, and on OCT you can see the disorganization and all full thickness layers of retina being involved. And as you see, start the treatment, it starts resolving, the reflectivity is decreasing, the thickness is decreasing, and the area is now being, so now there is necrosis that you can see, and it is more pronounced when it is almost complete to healing. The problem again with these infections is that there is recurrence, so there are chances of almost 30% of the people recurring in 1 year and around 50 around in 2 years, and these are more commonly seen patients who are younger age, who are immunocompromised and either pregnant or have undergone a cataract surgery. To summarize, basically they have a very characteristic appearance, so at least in the typical form it's not a very hard diagnosis to make. What you should be aware of that they recur, so the treatment should be adequate. In atypical cases, you can actually support it with serology, and anti-toxoplasma therapy is basically what we give as Septran or Bactrim, and adjunctive therapy in the form of steroids helps in controlling the inflammation and preventing unwanted outcomes. Thank you.
Thank you so much, Dr. Shorya. So the main thing to emphasize here is that this is a clinical diagnosis. So once you have that white lesion, and if you also have an adjacent scar, then there's nothing more to add to it. Sometimes the scar may also be in the other eye. So also see the other eye carefully. And if there is also vitritis, again that makes it very confirmatory. So serology is not necessary. Serology may be false positive also. And what he's talking about PCR, that we generally reserve for cases which are atypical. So if you have those large patches which may mimic an ARN, which don't typically look like a focal patch, we have the confusion. Then once we are doing vitreous tap, we send it both for herpes viruses, CMV as well as toxo these days, because some of the cases we have found to have toxo. And another thing I wanted to emphasize was the arterial involvement. So that chirales, please look for it carefully. That is not just a feature of toxoretinitis. Any retinitis we have seen, once it starts resolving, once those vessels start becoming more clearly defined, you can see those exudates on those arteries. We have seen it in CMV, we have seen it in post fever also. But again, the presence of those chirales arteriolitis means that you are dealing with something like a retinitis. Sometimes a self-resolving retinitis, only sign might be that chirales, and you would know that that patient has a retinitis and now a thin retina over there. So any questions from the audience on the basics and toxo at present? Yeah. But had it gone on to a chorioretinitis, or it was just a chorioretinitis? Okay. So Dr. Devesh is saying that even in panuitis, choroiditis, you can see chirales. But yes, retinitis typically it's a sign of retinitis. Yeah, please go ahead.
Do you treat the extramacular toxo lesions?
Yeah, so the literature says that if it is an extramacular, it is not vision threatening, you can actually just leave it, it resolves by itself. So it's not required to treat those lesions.
But yes, any lesion close to the arcades, or if some lesion is causing vitritis, causing loss of vision, then I would rather treat the lesion. Yeah, but literature, like he said very rightly, might say that you leave it. But once the patient is symptomatic and it's close to the arcade, why do you want the scar to go big? I would rather treat.
Recently, I came across with a case. It was quite far from the macula, but I observed it. After 2 months, it became scar, but it recurred again.
So even with treatment, it can recur because all these therapies are bacteriostatic. But like I said, depending on the size of the lesion, location of the lesion, symptoms of the patient, if it's a small lesion you have decided to observe, fair enough.
I think the important issue in that patient would be to look for immunosuppression. If there is any immunosuppression, then we need to treat it irrespective of the place. But if it is an immunocompetent patient, then we may choose to observe small peripheral lesions.
So before we go on to, yeah.
4 weeks or 28 days, and for the first year the recurrence rate is about 30 to 40%. So can we consider them for a prophylactic therapy for a longer duration of time? Are we doing it?
There is literature that says that you can actually continue the bacterium or septoran for a year to prevent these recurrences. So as prophylaxis.
So there are a lot of articles I think from Brazil where people have given it for years and years.